Welcome to Project Echo Geriatrics. For those of you who are joining for the first time, a special welcome. And for those of you coming back, I'm glad to see you again. We have a great session today. We always run these the same way, which is starting off with about 15 minutes or so of didactic on a focused topic, usually relevant to primary care geriatrics. And then we have a little bit of time for questions and discussion. And then finally, the heart of Echo is our case discussion. And we have a fantastic case presenter for the latter part of the session. So we'll start that probably around a little bit before 1 o'clock, I think. So welcome to everyone. We have a great speaker who you probably recognize. She's been one of our Project Echo panelists, Leigh Mike. She's a clinical associate professor in the Department of Pharmacy, and she's the assistant director for education in the Pline Center for Geriatric Pharmacy Research, Education, and Outreach. And she gave us part 1 of the talk she's giving today about the hidden risks of medications, and it was fantastic. And we're hearing part 2 now, and I'm really excited to hear what you have to say. She presented some of this at the American Geriatric Society meeting, and it was a very popular talk. So thanks for giving us an encore presentation for us specifically. I appreciate it.
Yeah. So thank you. Yeah. So this is a companion piece. If you're curious about the first portion, if you weren't able to attend that session, the recording is available on the YouTube channel. And I'm going to be presenting the second piece, the companion piece, with some new additional information. So even if you were attending my talk at the American Geriatric Society meeting, I've got some new stuff to share today. So I'm going to start sharing. Okay. So the topic for today is the hidden risk of medications, and the major area of focus is on the inactive ingredients. And as we move through the session, maybe you'll kind of pick up on why I've mentioned inactive, because in some of the cases, although they're not the active ingredient for the desired pharmacologic effect of the medication, they are nevertheless in the medications that our patients may be taking, and they may have some activity that we're not really keen on sharing. Let's see. Okay, so our objectives for this session are to explain the implications, including the adverse effects of various medication formulations that are used in older adults, and then apply that knowledge of formulations to assess for the implications in older adults. So before we move any further, I want to just refresh your memory, this sort of like mantra of geriatric pharmacotherapy practice. And I want to use this to frame the remainder of the talk. And for those of you who saw the last round, please don't mess up this. This is a spoiler alert. Don't give a spoiler alert. So let's start with this quote, and something that as pharmacists or as providers taking care of older adults kind of like forefront of our mind, particularly with medication. So any symptom in an elderly patient should be considered a drug side effect until proved otherwise. So that's the framing for the remainder of this talk. So because we're talking about dosage formulations, I wanted to give you a very brief background on pharmaceutical sciences. I know there's 2 pharmacy students on the call, at least the last time I looked. They will tell you that they get a whole semester's long content on pharmaceutical sciences. But for the purpose of this discussion today, really want you to just focus on that the pharmaceutical sciences involve discovery, development, manufacture, and use of safe and effective quality medications and products. And like just further drilling down a little bit, the purpose of our talk is that we're going to focus on how medications are formulated, how they're made to get a final product. And the exact examples that I wanted to share with you today are inactive ingredients. So let's move on to our inactive ingredients. So you may have heard about these. Sometimes you might have heard them called excipients. That's what they're called in our pharmacy training. But they're really basically, the definition is it's any ingredient of a drug product that's not the active ingredient. And so why do we have inactive ingredients in formulations? There are many reasonable, rational reasons for having the medications with inactive ingredients. So these inactive ingredients may offer some stabilization long-term to guard against degradation. There may be some bulking up of solid formulation. So for example, if the dose is in milligrams or micrograms, the quantity and volume is really small to be taking that. So it's bulked up with other agents. There may be some additional excipients or inactive ingredients added to also and facilitate absorption, reduce the viscosity of something, or enhance the solubility. The examples I wanted to share with you, just to kind of get your head around it, it's like really concrete example, is thinking about chewable calcium supplements and gummy vitamins. So you think about each one of them. The calcium supplement is chalky, it's a big pill, it's chewable, it kind of crumbles apart, gives you that kind of coating on your tongue, versus the gummy vitamin, which is a gummy. And so each of those will have different active ingredients intended to give it the final form, the quality and characteristics you're desiring. So whether it's flavoring, sweetening, bulking, anything else that can enhance the texture or enhance the solubility or adherence. So this is what we're talking about. I also wanted to mention that there are some intended active ingredients which are designed, put in a medication product by design. And then there are some unintended inactive ingredients. And this is the new stuff that has just come out. I saw the news reports back in August about some of the store brand cough and cold medications having a benzene component into it. And as I delved a little deeper, I see that there are some benzoyl peroxide topical dermatologic preparations that also have benzene in them. So these are inactive ingredients that are not even intended to be there. In the case of benzoyl peroxide, there's some chemical degradation that leaves the benzene as part of the final formulation or product. And then in terms of the cough and cold medications, one of the raw ingredients for making the sustained release portion of the cough and cold medications has some benzene in it as a solvent. So good news is that the brand products are free of benzene, but the store brand or the generic cough and cold products may or may not. And there's some investigation, and the FDA is trying to address this issue. And really, there's a whole body of research on this, and that's not the intent of this talk. I just wanted to put it out there that you may have heard this, you may have seen this. There was a short story on NPR related to the cough and cold medicine. So there are people working on this. So back to the inactive ingredients that we want to be in our product, it's kind of easy to find where they are on an OTC label because they're right there on the label. And so you can see here the inactive ingredients listed in this product, which includes food dye, some lactose, and some other things that kind of help with, the formulation. So OTC products, it's easy to identify the inactive ingredients. On a prescription product, it's a little bit more challenging. So that you can see this is the label on a box of atorvastatin, and you can see all kind of stuff in there, but no active ingredient information. So in order to see that, you would actually have to look at the prescribing info, also known as the package insert, to look at that. And that would be under the description of the product. So you can see on this one, it has a whole bunch of stuff. It's got lactose, it's got magnesium, mannitol, all kind of stuff. So it is required to be listed, but it's a lot more challenging to find for our for prescription products. Then diving into some of the inactive ingredients that may be more concerning to us, and I've compiled a short list. I want to caution you that this list is not all inclusive, but these are certain inactive ingredients that we need to be careful about when thinking about recommending or prescribing medications to patients. So for example, patients can have allergies to things, and some medications are formulated with food dye. For example, tartrazine, FD&C yellow number 5. Some people may have an allergic reaction to that. Some products are formulated with sesame oil or soy products or egg lecithin or peanuts. So knowing that your patient has an allergy, one of these, you would definitely want to avoid prescribing or recommending a product like that. So kind of obvious, we want to avoid that one. Lactose, if you had paid attention on the prior couple of prescribing labeling that I showed you, lactose is in a lot of products, and it's a lot of times used as a bulking agent. A little powdered lactose, it bulks up, it makes it easier to make a tablet that is easier to handle and swallow, or a capsule that you can pack full of, the powder. So lactose, certainly if your patient has a lactose intolerance, depending on the dose they get, they can be pretty sensitive to that. And then for patients with irritable bowel syndrome, this could be problematic for them also. Then also there are, so I'm going to skip ahead to gelatins and gluten and then move back to the non-absorbable sugars. So gelatin is used to make capsules, and some gelatins are derived from animals, which include pork and beef sources. And so knowing that, this is the source of this gelatin, that may not be suitable for people who are following vegetarian, vegan diet, or who are otherwise avoiding pork or beef in their diet. So recognizing that is an important consideration when recommending or prescribing a medication. And then gluten, some medications have modified food starch in them. The likelihood is low of causing a flare of celiac because I think it usually is below the threshold, the parts per million threshold that's of concern. But just be aware that there may be some modified food starch that may contain some amount of gluten, which would be concerning for people with celiac disease. Okay, now back to the non-absorbable sugars. I want to spend the bulk of the time talking about that. So what do we know about non-absorbable sugars? Well, there are a number of them. They're meant to enhance palatability, offer some sweetness. And you can think about some of these things are even in chewing gum or things like that, just to help with the palatability. Sorbitol, which is at the top of the list, is a known laxative. Anybody who's ever recommended or administered activated charcoal would know that it has sorbitol mixed in it because it's meant to cause diarrhea. So the activated charcoal is meant to absorb. In the case of an overdose situation, the activated charcoal absorbs the drug. The sorbitol helps eliminate the drug from the body through diarrhea, essentially. Sorbitol can cause GI symptoms, gas, urgency, bloating, cramping, and that is a dose-dependent thing. So if you know that, if you know patients are on it, you can see that doses over 20 grams per day can just cause diarrhea. If the patient has less, it may just be some of the GI symptoms. There's also the possibility of taking multiple medications with non-absorbable sugar. And so what you would have to think of is the cumulative exposure across different medications. And you can see on the right-hand side of the screen, I've pulled two commonly used over-the-counter medications that may be used by older adults, particularly if they have difficulty swallowing, where these are both suspension formulations, a suspension and a capsule. Can be used. You can see that the Tylenol has sorbitol and sucralose in it. The naproxen has mannitol and sorbitol in it. So if you can imagine somebody has multiple over-the-counter medications, the cumulative effect may cause a problem for them. I observed this when I worked in the intensive care unit, especially for patients who had trouble swallowing. We'd switch their medications to forms like solution forms, suspension forms to help kind of administer the medications. And then the next day, everybody would have diarrhea. And then, then the team would be like, oh no, we need to figure out if this is C. diff or not. And part of my kind of like contribution is like, let's look at the meds because maybe that's more likely to cause this than C. diff. So I'm bringing this to your attention just for your own kind of knowledge and adding that to your potential differential. By way of kind of explaining this through a case example, I found a report that was put out in the Canadian Journal of Family Medicine. And this is a 56-year-old woman who presented with a long history of diarrhea and unintentional weight loss. And she had pain and urgency and incontinence. And she had a very, very thorough and extensive workup, including ID specialists, multiple courses of antimicrobials, imaging studies, endoscopy, colonoscopy, and nobody could figure out what was going on. And then finally the patient was referred to a primary care provider, and that team was like, let's do, I mean, they got a plain film and they noticed gas on her in the imaging study, and they're like, we're going to ask her about what she's eating. Is she eating gassy food? And what they were able to determine is that this patient was chewing the equivalent of 1 pack of gum every day. And so they're like, and it was one of those sorbitol containing chewing gum, so the sugar-free kind. And once she stopped using the chewing gum, guess what? All of her symptoms went away. And so if you could just use your imagination and substitute a medication containing a non-absorbable sugar for chewing gum, you could see how your patient may have a similar situation. A little bit analogous too, some of these sugars are used to sweeten the no sugar added baked goods and things like that. I know I've had patients with diabetes using those products to avoid the sugar end up with diarrhea because of the non-absorbable sugars in their food products as well. So yay, shout out to primary care. They figured it out. They cracked this case. The $1 million workup ended up being a chewing gum. I think the lesson here for us is to think broadly and, consider all potential sources, including things that are in the products that we are consuming. Lastly, in terms of inactive ingredients, there is some movement in the field to recognize and investigate whether certain inactive ingredients are more likely to cause adverse events. So you can see the top papers from an epilepsy journal. And there's some sort of kind of word on the street that switching between products, especially with the anti-seizure medications, some patients may have variable response to those as they're switching. And so there's a group who's looking at maybe identifying whether it's an inactive ingredient that is contributing to some of the variable responses that patients are seeing. So this kind of early work still, but there's work on it. Additionally, the Food and Drug Administration is developing a pilot program that reviews the safety of any ingredient that's added before the product is manufactured. So this really doesn't address all of the ingredients that are already out there, but for any new type of ingredient, there's going to be some work on kind of more of a preventive practice. So this is ongoing, so maybe I can come back in a few years and share some new developments, but we'll see how this unfolds in the next few years. In the meantime, what can you do today? Well, one thing I might suggest is that you add inactive ingredients to your differential for new symptoms. And again, inactive means it doesn't have the pharmacologic effect that you want, but it does have some effect that it can be very undesirable for a patient. So thinking about dosage forms, has there been a change in dosage form? Has the patient switched from tablets to capsules to suspension or some variety of that? Or potentially even change of manufacturer. If you were to look more deeply at that epilepsy research paper, different manufacturers of the same drug product active ingredient will have a different combination of excipients. So maybe even switching between manufacturers could help you start investigating a little bit more. And then ultimately, when you're thinking this through, you've avoided a prescribing cascade. So you're not adding an anti-diarrheal agent, which then maybe sometimes causes constipation, and then you're kind of in a vicious cycle. So my advice is to add this to your differential. And, remember that case from the Canadian Family Medicine Journal about the chewing gum, and like you can have that win too. All right, so in summary, recognize that inactive ingredients can result in adverse events and effects, even though they're inactive. And then making sure that you're assessing for those hidden risks can help improve patient outcomes. Lastly, I wanted to revisit the comment and the quote that we started with and add my own little kind of interpretation of that. So any symptom in an elderly patient should be considered a drug side effect or drug formulation effect until proved otherwise. And with that, that concludes my presentation.